Welcome to this Mental Health Innovation Network webinar. I can see that more and more participants are joining. We have reached a mark of 100, but I'll wait for another minute for some others to join before we actually begin. But in the meantime, welcome to those who have joined, and also welcome to all the panelists who are here with us. So welcome again, and let us begin now. My name is Shekhar Saxena, and I'll be your moderator for this session. This webinar is arranged by Mental Health Innovation Network, and we'll be discussing educating medical and nursing students in mental health, neurological illnesses, and substance use care, a WHO guide for pre-service education. This is a guide that has been prepared and published in April this year. It's already on the website, but we will discuss in detail what this guide is, who should use it, and what impact the use of this guide will have. We have a very select group of panelists who will answer some questions, give their experiences and opinions, and will carry the discussion forward. I would also like to remind everybody that this session is being recorded. Indeed, the recording will be available to all the people who registered later after the session is over. I would also like to remind the participants that it is a very interactive session. So you are most welcome to ask questions within the Q&A tab of the Zoom that you are on. You're also uh, very encouraged to chat, share your experience, share your opinions, share even your name and where you're joining from within the chat. So if you have a question, the tab to use is Q&A. And if you have something else to talk about, it is the chat that you will use. And I hope all of you have read the guide. I hope at least most of you have read the guide, but if not, we will be presenting some of the details of the guide, and you will then come to know more. My last point, there is a social media posting possible. MHIN will be posting some content on the social media. So if you are on that, feel free to disseminate. Also, use your own content to social media so that the maximum number of people can become aware of that. With that, I would like to invite the director of the department that developed this guide, Deborah Kestel, to do the opening. Deborah, please.
Thank you, Shekhar. Thank you for the introduction, and colleagues all. Thank you. Good morning, good afternoon, and good evening. And yes, I'm the director of the Department of Mental Health, Brain Health, and Substance Use, and it is really a pleasure to welcome you today for the launch of this guide that, as Shekhar just said, I hope you all read properly. So we believe this guide is very important because in way too many countries, a cohort of medical and nursing students graduate unprepared to recognize depression in a mother, or to know how to properly manage epilepsy in a child, or how to respond compassionately and effectively to the needs of someone experiencing a substance use disorder. So we designed this guide to work with this reality in mind. And thanks to the expertise of more than 150 stakeholders globally, including people with lived experience, we consulted with all of them. Today's launch, we hope, will lead to more than introducing a technical resource. We are hoping it can support catalyzing global efforts to address one simple truth: mental health, brain health, and substance use is everyone's responsibility. And that responsibility must begin from medical and nursing education. However, trying to do so can only succeed through strong collaboration across our networks, and not just the professional ones. We need people who have navigated their own mental health journeys to co-teach empathy to future providers. We know that transforming medical and nursing education does not happen overnight, and we won't see immediate results. But a student trained today will not enter service immediately, and curriculum changes can take years to be fully implemented and show impact. But this is precisely why educational transformation is so essential for sustainable development. We are not looking to quick fixes. We are building the foundation for generations of health workers who understand that mental health is inseparable from overall health, from human rights, from well-being, and from broader societal goals, such as the Sustainable Development Goals. The long-term vision requires all of us. Thank you for being here and joining us in ensuring that the power of strong pre-service education is applied to our field and the concerns of people with mental, neurological, and substance use conditions and psychosocial disabilities. Back to you. Thank you again.
Thank you very much, Deborah, for setting the stage for why the guide was developed and what could be the impact of using this guide. I can already see some impact. 194 participants have joined. I understand that about 1,000 had registered. So I hope more will join. And if you are not able to join, then you will certainly get a recording of the webinar. And of course, the guide is online for everybody to read. At this point, I would like to invite the unit chief of mental health in the WHO department, Mark van Omeren, to briefly tell us about this guide. I know that it has taken about 3 years to develop this guide, and I know that there are many, many pages in the guide. So I'm sure you cannot describe everything in 10 minutes, but just let us know what you would like, the main key messages, and the preparation of this guide and how it can be used within that much time. Mark, over to you.
Thank you, Shaker, and thank you also for your support throughout this work together with Sharon Kramer, Brandon Gray, and Sean Lewis. It was fantastic to work with all of you together. Now, WHO calls in the World Mental Health Report for transforming mental health, and at the heart of transforming mental health is our human resources. And the human resources for mental and neurological and substance use, one of the key set of human resources are the healthcare workforce, and the heart of the healthcare workforce are doctors and nurses. So this guide is really important, and we're so pleased to give emphasis to this guide. I see that there's no. I just need to work a little bit with slide, and it's going to be there in 1 second, because I didn't put up the slide thinking that somehow I had done that. There we go. There's the slides, now the Zoom. There we go. And I go to the place where I share. Where do I see that?
Green button at the bottom of the screen.
The bottom of the screen, usually there's add more button, and there must be a sharing.
It's colored green.
There you go. It's so big I didn't see it. There.
As usual, the director coming to the aid.
There we go. Here it is, and I put it in bigger so it's visible for everybody. There we go. So I think many of us on this are familiar with the large numbers that we have in mental, neurological, substance use area, and that so few people get minimally acceptable care. And it's not that every single person with such condition needs to have immediately management or treatment of their condition, but they should have access to care through universal health coverage. And the reality is that we simply do not have enough specialists, so we need to do task sharing, and doctors and nurses in general healthcare are often the first point of contact for people with mental, neurological, and substance use conditions. But many graduate without the competence and confidence to fulfill this role. So what we mean, pre-service education is a term that's not used everywhere. So let me just describe what we mean with it. We mean the learning that medical and nursing students do before entering the workforce while completing their training. And in this guide, we focus on their first undergraduate degree at university. So there's many benefits. These include building early confidence and competence, reducing stigma among these professionals, and promoting early on person-centered rights-based care at the time that people's skills are more moldable and attitudes are more moldable. Of course, preparing graduates to manage these conditions alongside physical healthcare and doing it together improves outcomes, and using a future pipeline of professionals that can do this. And of course, every single specialist also had their first degree training. So by doing this, the whole health workforce will, from doctors and nurses, will have had training. And just to flag that nursing is, according to our atlas, the most common health worker for mental health are nurses. So really important. And it complements in-service training approaches that also continue to need, but has some advantages. For example, in-service training in many countries has a cost to it through daily spending allowances that are often expected. And pre-service training comes with an exam, unlike some of the in-service training. So that really makes it a very powerful teaching tool. Let's go to the next slide. So the guide was designed as a practical roadmap for decision makers and educators worldwide. It outlines key activities for enhancing curricula or developing new ones. We used an extensive process. These guides are not quickly created. We used did an extensive literature review. We did best practice documentation. We did 2 global expert consultations in person. We included people with lived experience to get their perceptions on how and advice how to improve pre-service training. And then the guide, all roads, all advice led to that we should do competency-based. There should be a competency-based approach, and for each competency, we need to define the attitudes, knowledge, and skills, which we did for care of mental, neurological, and substance use problems and conditions. But just this is not a one-size-fits-all solution. It's a flexible framework that can be tailored to wherever countries are and what they're looking for, their specific needs and constraints, which will be vary from country to country in terms of educational institutions and also healthcare systems. So this slide kind of summarizes the guide in a few words. And the guide outlines 4 phases to prepare and plan for change through situation analysis, advocacy, making a work plan, then defining the care tasks that are needed in the local health system, and then matching this with competencies that need to be trained, then enhance the curriculum through learning objectives, doing relevant assessments, but also training the educators so that they can deliver on the enhanced education, and then implement, monitor, and evaluate. And all of this the guidance emphasizes on needing for adapting to local context, and there's many examples in the guide. Now, the first phase was preparing and planning, as mentioned. So establishing a curriculum review committee to guide the process is key. It should be multidisciplinary to benefit from the multiple perspectives and ensuring that all care aspects of mental are covered. doing situation analysis, which again partly focuses on what are the local care tasks, so it could relate to the local resources, but also to the local legislation and policy and what actually a non-specialist health worker may do in the system. Then also raise awareness and secure support from all stakeholders, because this kind of work is not necessarily expensive, but it requires a lot of effort, and getting everybody on board is really important in developing a work plan and a small budget. Now, the next slide covers competencies, and that's probably for most technical folks who may have already been convinced about that we need to do this work on pre-service training, and already maybe less focus on process, but just on what is it, what should be there. After extensive reviews, we defined 12 core competencies that are necessary that we recommend. First is the foundational helping skills that includes like listening skills, empathy, then rights-based care, and then promotion and prevention. And that also covers understanding of how mental health is situated within different types of determinants, including social determinants. So the public health approach is mentioned there, is covered there. Then clinical emergency care, clinical assessment, clinical management, psychosocial support is often underlighted in more traditional curricula. Support for carers, and then adapting for special populations, such as women who are breastfeeding or who are pregnant. And then follow-up care, of course, and self-care, which would likely be the most popular aspect of the curriculum, given many people, including students, have mental health difficulties. So the guide breaks down, as I mentioned, each competency down into attitudes, knowledge, and skills, and unpacks it. So it would be interesting for look at table 3.1 in the guide and really see how for each of these 12 there are specific attitudes, knowledge, and skills that are covered. So this is here shown on the next slide with an example from clinical emergency care, how there are certain attitudes, certain knowledge, and certain skills that are specific to clinical emergency care. The next slide covers the defining of competencies, and again, keep highlighting here that the depth in which the selection and depth of competencies, it's not something that, there's one guide and it tells the whole world exactly what it should look like. No, it should be adapted for the context, and the selection and depth of the competencies will depend on the care tasks that doctors and nurses need to perform to address the local mental health needs. Then the curriculum, once the competencies are defined, then what's next? Well, the curriculum, most countries and most schools have a curriculum. It's not like they give the opportunity to make a complete new curriculum from scratch. Generally, one enhances the curriculum. And the enhancement of the curriculum gives can cover a number of different aspects. For example, how do you shift attitudes of future nurses and doctors? And the guide describes the effective ways of doing that by, for example, involving people with lived experience as co-educators. It also describes modern learning techniques such as case-based and problem-based learning, and participatory methods such as flipped classrooms, where students lead the research through presentations, seminars. But at the core of competency-based learning is, of course, skills development. And the central focus here of the curriculum is hands-on learning, for example, through role-playing, simulations, and real-world clinical placements. The guidance very much emphasizes the need to expose students to different healthcare settings for practical learning. The very conventional way of training students in the mental hospital is not recommended for learning how to how to provide mental neurological substance use care in day-to-day practice in non-specialized care. There's also inclusion of digital technologies to supplement clinical placements. Then, when the curriculum is when it's implemented, there's different strategies that are probably suitable for different contexts. And I will give an example for least resourced context next. But the guide will, for whatever level of context one is at, there is guidance for monitoring and evaluation for continuous improvement. But here on this slide, we discuss in a little bit more detail the situation of settings that are least resource. Let's say you're in a place that there is no money, there is available for this further work, and there is still much need for change. Are there things you could be doing? And we say yes. We say one can replace lectures with more participatory approaches. One can add case studies of mental neurological substance use conditions and problems in the curriculum, for example, within gynecology, within internal medicine, within emergency medicine. So there's different places where one can do it, and one can try to expand clinical placement beyond mental hospitals. And one can harness community resources by, for example, partnering with local NGOs, health services, or service user organizations to expose students to community-based care. So overall, we recommend, of course, for you to take action. We think actions should start with probably with local people at the university who see what can be done, and start with, if there's no resources, start with small changes to help medical nursing students develop attitudes, knowledge, and skills. But we urge you to be more ambitious and to go through the process of this guide to strengthen pre-service education in mental, neurological, and substance use care, and build a health care workforce equipped to address mental, neurological, and substance use conditions, and together reduce much of avoidable suffering. Thank you.
Thank you very much, Mark, for summarizing a whole lot of information in just a few minutes. I would request you to continue to be there and join the panel, but I have one question that has been already asked, in fact, by several participants. You have selected doctors and nurses, that is student doctors and student nurses, as the target for this guide. Can you explain why? And second, is this guide also to be of some use to other health professionals like midwives? There is in fact a participant from Sri Lanka who's a occupational therapy trainer. What is your message to people who are not teaching doctors and nurses in training?
Well, first, let me justify why we chose doctors and nurses. We had a consultation meeting and in Geneva, and the advice was given to start with doctors and nurses because they're the largest workforce in mental health care. But we also all agree that mental health and social care needs many more multidisciplinary approach and more than just doctors and nurses. We thought it's a good starting point, and if we would a little bit, the thinking was less is more. If we do this well, we can afterwards expand to other disciplines. For example, I would be extremely keen to do the same work with other undergraduate degrees that are relevant to mental health, but are not just mental health. For example, social work, occupational therapy, teacher education. So all of these need to have an element of mental health in their first curriculum And then beyond that, there's of course the specialties, people who are going to be a clinical mental health social worker. Yes, they need better curriculum too. And psychologists and psychiatrists, they all need addiction specialists. They all need better curriculum. But we wanted to make sure that given that much of the training right now in mental health around the world is very much on non-specialists, that we start with nurses and doctors, that we do that better. And I think it would be quite easy to move to other disciplines from here, because the process described is likely going to be very, very similar for other disciplines. But the exact competencies that we would recommend will differ. And that is, of course, it's a process to have an agreement on what competencies should be in that undergraduate education.
Thank you, Mark. And I assume that even for some other professional pre-service training, some of the competencies that are described in this guide might be relevant,
Oh,
and they
yes.
could read the guide and see to what extent and and which parts may actually be useful already for their kind of training. But thank you again very much for highlighting the competency-based model for this guide, which is the future. So we need to accept that and transform the training of these professionals using competence-based approach rather than the traditional theory-based approach, which has been there for many decades in this area. At this point, and I know that the time is passing by, I would like to introduce the panel. We are very lucky, very fortunate to have people who are joining us as panelists. We have Jose Javier Mendoza Velasquez, Melody Esukile, Carmel Clancy, and Mark, you will also be one of the panelists. I would pose some questions to each of the panelists, and I would request you to answer maybe in 2 or 3 minutes that question. And as I pose the question, I'll introduce each of the panelists a little more. So the first question will be to you, Jose. He's a psychiatrist with over 15 years of clinical and public health experience, was also the general director of the National Commission on Mental Health and Addictions in Mexico till last year. And he also led the development of the Mexican model for mental health and addictions and trained, well, that's a very large number, 150,000 primary care professionals in mental health services. Very impressive, Jose. So the question to you is, the first question, you worked extensively both in clinical practice and policy development. How might this guide help bridge the gap between what is taught in universities and what is needed in real world mental health service delivery? Jose, over to you.
Thank you. Well, good morning. I'm Jose Mendoza. I'd like to respond this question based on my experience working within Mexico's mental health system. In Mexico and certainly across Latin America, there is a clear, persistent mismatch between the time students spend in universities and what are they preparing for work in the real world. Most medical and nursing students receive more than the 90% of their training based in hospital environments, and most of them only for 1 year and sometimes even less. They are placed in rural or community settings that are real world. Often, this is the first time we are expecting them to act independently, facing complex situations like suicide, substance use, or emotional crisis. This guide can help people. This guide can change that. It offers a competency-based framework that shift the focus away from theory-heavy curricula to practical applied skills. Even more important, it's mental health is public health, not just psychiatry. And the guide includes foundational helping skills like empathetic listening, crisis escalation, and it also increases collaborative care and effective referral, especially in places where few or no psychiatrists are available. And in addition, it promotes human rights and cultural competence and provider self-care, which is really important when we are talking about mental health. Also, something that is really necessary is that this guide emphasizes team-based learning and interprofessional collaboration, because this is critical when we are studying, when we are practicing, we are not alone. We need to share this responsibility with people, and we work alongside nurses, psychologists, social workers, occupational therapists, uh, I don't know, community health workers, and all of us contribute to a more holistic model of care. Unfortunately, these interdisciplinary are rarely addressed in the programs. So in Mexico, we've trained this amount of people from many disciplines, and however, those efforts can only go so far without a strong educational foundation, and this is what we have to do. And if we want lasting impact, we must embed these competencies in pre-service education, so graduates enter the workforce already fluent in the principles of integrated community-based mental health care.
Thank you so much for explaining that. My second question to you is that although the guide is has a global audience and obviously it contains things that are useful all over the world, but there are regional differences, and working in Latin American countries, what adaptation do you think will be required for use in the countries that you know well?
Thank you for the question. I'd like to respond by focusing on how to adapting in a system like Mexico, which is divided into a lot of institutions, which is really, really important because we have to share the view, we have to share this optic with this institution. And also, we are in Latin America, and Latin America is a diverse region in terms of language, culture, infrastructure, legal frameworks. And however, there are shared priorities because we have been identifying through our communication with other countries that we share a lot of necessities. First, territorial adaptation, it's needed. This is not something that we can decide from a desk working only in an office. We need to go to the places, go to the communities, and the same training cannot be applied equally in Chiapas, Durango, or Jalisco in the rural areas. It requires territorial diagnostics, understanding which mental health conditions are most prevalent, what services exist, and who delivers the care. In Mexico's mental health model, we use local data to determine where and how to implement community-based training. And second, we need to shift to primary care because university programs are overemphasized tertiary care, specialized training. And this guide, by contrast, promotes the exposure to real-world settings, which are primary care, general hospitals, and even people's communities, people's homes. We must train students where people live, not where they are hospitalized. We need to change that. And also, we need to focus on interdisciplinary training in a formal way. This guide wisely promotes these shared competencies because sometimes we share a lot of things and a lot of responsibilities in the real world, and we have to work together, doctors, nurses, psychologists, social workers, especially in collaborative tasks like crisis response, case management, and community follow-up. And also, something that is really important in countries like mine, like Mexico, we have to adapt teaching strategies because we are resource limited. We have this guide also recommends methods such as flipped classrooms, role plays, peer learning, and the inclusion of people with lived experience as co-educators, these approaches are effective. We have been working with that in communities through the experience of mental health gap. And these approaches are effective, low cost, and help to reduce stigma. In summary, in the Mexican experience, we work with the local diagnosis, community focus, and the works interdisciplinary and active learning strategies. And I think it is completely available to adapt to across Latin America.
Thank you so much. That's very good to hear. And also, thanks for highlighting the importance of working with people with lived experience. That is very important to be followed. Next, I would like to introduce Dr. Melody Esukile. Pardon me if I am pronouncing your name incorrectly. Uh, Melody is Zambia's one of the first neurologists and serves as a lecturer at the University of Zambia School of Medicine and has been working a lot in identification and treatment of epilepsy in in her country as well as in some other countries in Africa. And Jose, you talked about being resource poor. Africa is perhaps the continent that is even more resource poor compared to Latin America. So, Melody, we would like to hear from you what kind of experience you have had and how do you see the guide helping in epilepsy management in your country and in your continent? And what aspects of the guide do you find most relevant for addressing the challenges that your region is experiencing? Melody, over to you.
Thank you so much, Saxena, and thank you for inviting me to this webinar. Yeah, as you said, the limitations are really large and the challenges in terms of human resource limitations are quite big. So, of course, I'll speak to my experience in Zambia. So, Zambia has had very few expatriate neurologists for many years. Now we've got local neurologists, but we're still only about 18 for a population of 20 million. So, I think just speaking to what Jose was saying is that we really can't focus on specialized training so much, but we have to put great emphasis on primary healthcare because many of our patients will first see a non-specialist before they even get to a specialist. So I really like the guide. I think there are two aspects for me that really stand out, and I think that are quite practical for us in Zambia or in Africa. The first being its competency-based approach. So I believe that the competencies that were proposed in this guide, they're actually cross-cutting across multiple medical specialties. So things like foundational helping, providing rights-based care. This is important, yes, for MNS conditions, but it's really true for all other conditions that if we think about it in terms of medical care. So I think that for educators, it becomes useful for us because we can actually incorporate it in the holistic medical training for medical students rather than segmenting it to say it's only for mental health, neurological, and substance use disorders. The second thing that's also quite useful about the guide is that there was consideration about the variations of resource availability. So considering that in some countries they have better resources, whereas in some there are lower resources than others. And so what this guide does is it actually gives options to say, okay, if you've got higher number of resources, you could take this approach. If you have lower number of resources, you can take that approach. And so that becomes very useful for our setting. So for example, I'll give an example in our setting where we've got limited lecturers. The guide talks about using teaching methods that could employ more of digital resources. And so one thing that we've done at our institution is where we use the flipped classroom that Jose talked about. So this is where we provide recorded video lectures, which are provided in video to give you the didactic knowledge. And then when you meet the students, you have case-based discussion. And so in that way, you kill two birds with one stone in that the students get their didactic knowledge, but at the same time, they're able to apply that knowledge. So you find innovative ways of expanding the limited resource that you have. So I think there's several ways and suggestions we can try to improve expansion of our limited resources. I think another thing, for example, is just taking a mentorship approach, and that's something we would adapt from this curriculum, is that involving those you're training. So if you train senior medical students through this curriculum, in subsequent years, get those students to be like tutors or mentors to their junior colleagues. And so that way you try to expand your limited human resource. So I find this guide really useful, and it's a guide which really promotes thinking about your context and adapting it to your context. And as we said earlier, of course, we've said medical students and nurses, but I really believe even at this stage, it's quite applicable to many different health professionals, and people can use it as a reference as well.
Thank you so much, Melody. You have explained not only the usefulness of the guide for your country, but also what kind of innovative mechanisms can be used in extremely resource limited settings. Because as we know, this guide requires further training material, it requires teaching, it requires supervision. So my next question is, you have already mentioned that digital mechanisms could be used. But in clinical practice, when you are actually teaching students and you have very few neurologists in the continent, what other innovative mechanisms, what kind of adaptations could you use to quickly cover a lot of students and give them actual clinical practice experience so that they can be good in their future career in identification and treatment of neurological disorders, which is so much needed in your continent?
Yeah. I mean, it is a very difficult question, especially the aspect of the practical teaching. So one thing that we do is videos really. So you try and do videos which demonstrate things. So you do say demonstration video of how you would interact with patient, or a demonstration video of doing certain examinations. But then, so the issue then is those videos can be used as a teaching guide, say for a non-specialized doctor. So you could have neurologists who've done videos of certain, say, stroke, for example, and then you have someone more junior take some students on a tutorial based on that video as a guide. Something we haven't quite employed yet, but which the guide mentions, and I think is something quite useful, is where you have people with lived experience being part of your teaching. So thinking about, say, if you have a seminar and you have a person with lived experience come there and also share their experience. I think giving students, it will be a bigger group of students, but giving them that one-to-one chance to interact with an individual with lived experience can also start expanding, or at least broadening their minds in terms of how to relate with patients. And as I mentioned before, I think one thing that we really encourage as well in our program is, particularly with the clinical rotations, you've got a senior rotation and a junior rotation. And in all the specialties, we always encourage the senior students to actually serve as mentors to junior students, and to hold tutorials, to hold discussions group with them. So I think that becomes really key in this type of competency-based curriculum, is everyone should be adopted as offering some form of teaching at some point. And it really can start at the top, where you've got even patient videos of certain conditions, you've got recorded lectures, recorded demonstrations, but trying to use all resources available, the nursing staff, to offer some form of teaching in a particular area.
Thank you so much for explaining more. We go on to our third panelist. This is Dr. Carmel Clancy. He's the director of Center for Credentialing and Accreditation of International Consortium of Universities for Drug Demand Reduction. And quite importantly, she had earlier occupied the position of the Dean of the Faculty in a university. So she actually knows what are the challenges and also the potentials for incorporating changes in curriculum. So Carmel, I
Yeah.
come to you and ask you a very direct question. What opportunities do you see in integrating substance use content across different areas of medical and nursing curricula rather than isolating it in specialized modules?
Yeah, it's a really important question. And thank you for both the invitation and the possibility of speaking on this. This has been something that has been very core to my passion for many, many years, in that recognizing my own background is nursing and recognizing we have 28 million nurses globally in the world. In frontline positions, the opportunity to increase education around mental health and substance use, to me, seems almost sort of why it hasn't happened so far. I'm really unclear, in that if you look actually at the history of this particular subject within curriculum, particularly in nursing, and I think it's similar in the medical side as well. So this guidance is really a fantastic opportunity to set the record straight, is that on average in a 3-year undergraduate nursing course, you may, if you're fortunate and you have curriculum and faculty that can deliver this subject, you would get about 3 to 6 hours of training specifically. So we know already, and this is in advanced curriculum, maybe Western universities where there are maybe greater resources than many other countries in the world. So we know that this is a huge gap in the curriculum. So I'm delighted that this particular framework has been introduced. And I certainly, if we agree with the premise that there is no health without mental health, then really it tells us and tells me, certainly as a previous dean in a faculty of health, everybody should have this on their curriculum and embed it in, not as a specialist, but base it as a basic core competence that every healthcare professional, and I'm really pleased that there are other disciplines asking the question, what about pharmacists? What about midwives? They're absolutely correct. This is everybody's business, in my view, not just indeed nursing or medical students. So I think for me, the embedding it across the curriculum is essential. If we take and look at the exposure to substance use and the onset of the condition or the challenges, often they start at a very low level. So by introducing this as a core basic curriculum and not seen as a specialist area, it starts to change the tone, in my view, about what is actually required. And I think that this framework starts to particularly address it and beautifully tells you and guides you, almost taking your hand through how you can implement it right across the different curriculum. And I think that for me, the universality is huge if you look at the way the framework is set out. The curriculum D, as I call it, decentralization, showing how you can actually vertically put it through all the different subject areas, be that from primary care into, sort of psychiatry indeed, and then we've heard other areas of medicine where we know that there is comorbidity happening, where we know that there are all of these challenges. By letting our students know that this is not just a specialist area you do at a postgrad, or indeed something that you might be interested in going into after you've trained, you need to come out ready to run, so to speak, from your medical and nursing training. So I really am delighted to see that the curriculum has been, in a way, and the framework has been, in a way, sort of plotted out. So for me, looking at this straight from the beginning, you can see how you can take this in different curriculums, drop it in, and in effect expose your students. So I think it's an excellent beginning, and highly recommend it to anybody who is starting to look and revise their curriculum.
Carmel, thank you so much. You're highlighting the importance of integrating it within the curriculum and making it really non-specialized. That's what WHO wants everybody to do.
Indeed.
I have one question, and I would like you to answer quite briefly because we also need to take some questions from the participants. Even within the area of substance abuse, there is likely to be quite a bit of difference between regions, countries, and also in future. What you teach now might change in 5 years' time by the time people go on to practice. How does the competency-based model prepare students for varied experiences and challenges now and in future?
Yeah, excellent point. Ultimately, anybody who's listening in or future listening into this webinar will know that universities, in terms of validating their programs, don't validate it once off. They need to go back, they need to revise. They usually anywhere between 5 to 6 years would be expected by their university within a validation process to review their core curriculum and how they're actually making sure that they're future-proofing it. So ultimately, yes, this core competency set that we're looking at the moment is a great start, but it's the start. One has to not become complacent. One needs to be future-proofing, as you're very nicely, gently directing us, that this is a living document, so to speak. It's not something that you say this is the one way and this is the only way you do it, but that we need to keep revisiting it. And of course, we need to continue look at, I mean, in the principles of the framework, it talks about continuous learning, lifelong learning. We know that this particular, both mental health and substance use, is a constant changing environment. So those who are in the curriculum development side, the faculty, need to be aware this is the beginning, nice framework, but you will need to continue to revise it and to be open-minded and looking constantly at the evidence.
Thank you. That's really very useful. I would like to pick up some questions from the rich discussion that is taking place in the chat, as well as some very direct questions. And my next questions, in fact, two questions, are to my colleague Mark. The first one is on supervision. Obviously, teaching as well as further work requires a lot of supervision. What is your view about who would be the supervisors? And I know that Jose as well as Melody has talked about it a little bit, but what is the WHO position about who should be the supervisor, the teacher and the supervisor for this implementing this guide? And how do you, and the second question is, how do you envisage some kind of monitoring on the fidelity of implementation of this guide? Any thoughts?
These are interesting questions, and they are not preset, so I have to think about them. But it reminds me of this clever comment that a mental health nurse trainer once told me, and he said, "Training without supervision is entertainment," which I very much like. So the question is saying it's a very important question. I think the supervisors should be people who are competent in the intervention. So in WHO, we are perhaps less focused on licensing and who has the right to do what. Is very much national concerns. So we don't really try to interfere so much in that. Those are local decisions. But in general, it's most important that not that the supervisor has the right clinical degree, but the supervisor is competent in the intervention. So that may mean that a family physician maybe end up in a country where there happens to be lots of family physicians supervising doctors, or it may be a pediatrician maybe doing rather than a child psychiatrist. And in nursing, there will be different people who will be appropriate. It depends really who has the competency.
Yeah, and does WHO have any plan to monitor the implementation of this guide? How do you know that it's making an impact?
This is always a challenge for WHO because we don't control how people use it. We're looking at very things like web statistics to see how often it's being used and all that. But we would love to set up a system that follows that provides follow-up on the guide. And if people on this listening in have suggestions for that on how to do that in a meaningful way, so that so that the guide becomes reality. I believe there's many people out there who really would like to work on curriculum change and do not really feel empowered to do it, but it has to start locally. It is not something that we can impose. So, but we were very keen looking for collaborations in this regard.
And as you talk about collaboration, I would also like to remind everybody that we have Africa CDC here, a potential collaborator. In fact, Dr. Mohammed Abdulaziz is sitting in the same room as Mark. So Welcome, Dr. Abdulaziz. I would like to invite you to comment very briefly on how do you see the use of the guide in the region that you represent?
Thank you so much, Chair. Thank you. In Africa, we know that some of the challenges, public mental health challenges that we have include treatment gap. We have archaic or old legislation on mental health. We have lack of integration of mental health into PHC and our ability to really reach out and stop stigma and other public health issues that affect mental health strengthening. And we know that the formative age of medical doctors and nurses is during the pre-service training. Many of these serious challenges in the mental health system can only be done with public health tools. And once a medical doctor or nurse passes that stage, attitudinal change becomes very difficult, impossible sometimes. And for some of us that have been intervening across Africa in this area, we see one of the major problems is the resistance we face from doctors and nurses to use public health tools for change. Now, the WHO pre-service guidelines for mental, neurological, and substance use is, while reviewing it, I was really taken to see how much detail and how much adopting this guidance can help in solving some of the problems we have in the area of mental health. It can help us get doctors and nurses that will accept tax shifting, tax sharing, that will accept other public health tools in the process of taking care of some of the challenges we have. And we can do it at a very early stage, in the formative age, instead of when any doctor or nurse know that by the time you finish training, a lot of your thinking and attitude to the work you'll be doing in your career has already been formed. So we thank WHO for these 12 competencies that, if applied to the pre-service training on the continent, will go a long way in helping us to have a workforce that can help with solving some of the challenges we have in the area of mental health, neurological, and substance use disorders. We are very ready to work with WHO in the implementation of this strategy on the continent of Africa. And in fact, Africa CDC, in one of our programs, is already designating pre-service workforce development as a pillar for us to use in the workforce development for the area of mental health on the continent of Africa. Thank you for having
That's
us.
very good.
Back to
I
you.
think Mark will be very happy to hear that he has a potentially large collaborator right in the room. That's great. I know that many other questions have been asked, and we perhaps won't have time to cover that. But again, just to remind all the participants that a recording of this will be available from MHIN. I have, in the last couple of minutes left, I have an action-oriented request. I would like each of the panelists to tell us what actually and very concretely they will do in the next 1 month to make the guide more aware and also aware to people, and also to encourage its use. So just in a sentence or two, and eventually I have a question to Mark also at the end. So we begin the reverse way. Carmel, please.
Thank you. You introduced me, as you said. I'm director of a credentialing centre within ICU-DDR. We have over 500 universities as part of our network globally. So we've already actually started to promote the guidance in anticipation of this webinar and this launch, but also in terms of letting our members know that this guidance is available, and then hand-holding and taking people through that should they wish it. So we'll be promoting it very, very actively in all of our events through our partnership.
Thank you, Kamal. Melody?
Thanks. I think I'll start small. Firstly, I'll make sure I go and speak to my dean at my university and see how we practically can work together in a multidisciplinary fashion to see how we can implement this guide, and then share with the other universities as well, and yeah, build it up from there.
That's an excellent answer, Melody. It's not starting small, I think it's starting very concretely. Talking to your dean will be a very useful exercise. Jose?
Thank you. To operationalize this in Mexico, I propose a pilot project with IMSS Bienestar, which is the main institution working on primary care in Mexico. So we are well, not negotiation, but designing a cohort working for nursing interns and social service doctors in priority territories.
Thank you. Excellent. And I would like each of the participants, right now there are 224, to think exactly what they will do in the next 1 month to make the guide more useful. And if you have your thoughts, you're welcome to write in the chat. You're welcome to come back to Mark or to MHIN and suggest things which could actually be useful for other people. My last question as a closing is to Mark. You obviously work with the team that is within WHO for many years, produced this guide. You had the backing of your own director, also of your director general. If in April 2026, you happen to meet your DG in the corridor, and and you tell the DG, well, you supported us in making the guide, you wrote the forward, you helped us. What would be one accomplishment that you would like to talk to DG about to say this has been an impactful and rewarding exercise?
Oh, I would love to tell him that there will be 100 educational institutions around the world that are on their way, actively on their way on curriculum reform, or where already changes have been made within the existing curriculum by the way it's executed through different participatory activities, etc., through the activities that are described in the guide. And I would also say that I have responded, me and my team have responded to all requests that come in our inbox related to pre-service, this guide. Whether we can always say yes to the request is something else, but we will respond to all requests on next steps on implementing this guide. And I will tell that to the Director General to make him feel and to reassure him that we're responding to what people's needs are on the ground.
That's an excellent 1-year plan. And I would like to request all participants here to help Mark in reaching that goal of influencing 100 curricula all along the world. So the count is on. Keep Mark's inbox full. Help him with suggestions. Help him with making the task easier. I again want to thank all the panelists and indeed all the participants, and lastly, MHIN for organizing this webinar, getting so many people to interact and to make the task of WHO in encouraging better education for medical and nursing students a reality all over the world. Thank you again so much, and bye for now.
Thank you. Bye.
Thank you.
Thank you,
everybody.
everyone. Thank you.